Hi, everybody. Welcome to today's episode of Oncology Data Advisor. Today, I have the honor of being joined by Janine Joseph, Senior Research Specialist in the Department of Cancer Prevention and Control at Roswell Park Comprehensive Cancer Center. Last week at the ASH annual meeting, she presented her team's abstract entitled 6-Month Resistance Training Interventions are associated with improvements in fatigue and pain in multiple myeloma patients. And today she's here to tell us some more about this research. So Janine, thank you so much for coming on today.
Oh, thanks so much for having me. Happy to be here. So my name's Janine Joseph. I'm a senior research specialist and predoctoral trainee at Roswell Park Comprehensive Cancer Center in Buffalo, New York. As Kira mentioned, I was presenting at ASH on Sunday in San Diego, presented work that was from the lab of Dr. Jens Hillengass, who is the chief of myeloma and amyloidosis at Roswell Park. So this was a collaborative research effort, and I was fortunate enough to be able to work on the research team with him and his team.
Awesome. I'm looking forward to hearing more about this research today.
Thanks.
So for a little bit of background, how is exercise currently viewed in multiple myeloma? Is it usually recommended or not recommended that patients exercise?
Yeah, well, historically, doctors have been reluctant to recommend exercise in this population because myeloma is a disease of the bones, of the bone marrow. And so osteolytic lesions or bone breaks are common in this population. So it's a painful condition to begin with, but it's something that doctors have been afraid to push patients to exercise because they don't want their patients to have broken bones. And make things worse. So there's always been this fear that resistance training in particular would be contraindicated in this population. But that is beginning to change. I mean, there have been a lot of number of studies in recent years, in particular, focused on feasibility and safety of exercise in this population. And it's becoming more and more obvious that when done properly, these patients can take advantage of the benefits of physical activity and resistance training in particular.
Amazing. So what were you investigating in this study?
So the results I presented at ASH were focused on 2 trials that we conducted. One was a pilot study that was started right around the time that the COVID epidemic started, and it had 2 cohorts. We looked at a in-person supervised resistance training cohort, 6-month exercise regimen. The participants came into Roswell Park twice a week for 26 weeks, so 52 times in total, and participated in 1-hour progressive resistance training intervention with a trained nurse and physical trainer, Michaela Hillengass. And that the other arm was added to the study because of COVID. There were people that were afraid to come into the hospital at that time. No one knew anything about the degree of contagiousness of COVID, or if people, we just didn't have a good handle on how to really do things in person safely. And so this other arm was added, which was a home-based, unsupervised walking intervention. Basically, what we did was we put Fitbits on these patients and used technology to remotely increase their active minutes goals to get them up to the physical activity guidelines for Americans, which those minimums are like 150 up to 300 active minutes per week. So that was more of a walking unsupervised arm. And we were looking at primarily in that study, we were looking at feasibility and safety, but we were also secondarily looking at other endpoints, including immune function, physical function, and patient-reported outcomes, such as what I'm going to be talking about today. That study ran until 2022, and then we had we have an ongoing study that it's focused entirely on supervised resistance training again, but instead of being an in-person intervention, we have these patients working out using Microsoft Teams. So it's the same trainer, it's the same intervention, but it's just conducted virtually. So it's more scalable, and it is more logistically feasible for many people to work out at home. But it's the same number, it's 52 sessions spread out over 6 months. And so we're looking. This is a full blown trial. It's not a pilot study anymore. We're looking at a number of endpoints, in primarily immune profile changes, and also looking at patient reported outcomes, microbiome, physical function, things like that. So yeah, it's really exciting. So what I did at ASH was I presented the patient reported outcomes from the pilot study, and then the preliminary results, or like the interim results from the ongoing study.
Amazing. That's great to hear about. And it's definitely exciting that there are so many options for exercising at home as well. I'm sure it makes it accessible to a lot more people than it would have otherwise.
That's true. Yeah. I mean, I know it's for me, I'm the kind of person, I hate going to the gym, but I'll watch something on YouTube, or I'll do my own little routine at home, and if I'm inspired to do it, I'll do it. So, and then when you have a great trainer like Michaela, she and Dr. Hill, she's Michaela Hillengass, Dr. Hillengass, they are married. And she's just such an expert in what she does. And she is so motivating, and patients come out of the trial just, having with their eyes open, like, this is exercise. Who knew exercise could be this good? So,
Mhm. That's
yeah.
amazing. Sounds like a lot of fun too.
Yeah.
So what were the results that you presented at ASH?
Well, I presented results focused on 4 different patient reported outcomes: pain, fatigue, anxiety, and depression. And so pain is particularly important in this population because, as I mentioned, the osteolytic lesions and just other bone instability, and patients are afraid to move. So even if they don't have, particularly fragile bones or breaks, because they're not moving as much, they tend to lose function and experience more pain. So we wanted to focus on pain and fatigue, which are really important in this population, and anxiety and depression. Cancer-related anxiety and depression are really significant factors for a lot of patients in many types of cancer. So yeah, so the outcomes were, in brief, we saw that the home-based unsupervised walking intervention was not associated with significant changes in any of the 4 measures. There was sort of a suggestion of improvement in fatigue and pain, but it wasn't statistically significant. But where we did see significant improvements was in the supervised resistance training intervention. So we saw significant improvements in the in-person supervised resistance training intervention in pain. And so that was during the intervention. From the baseline point to the end of the intervention, patients were reporting significantly less pain by 2 metrics. And that those changes were not lost after the intervention. And in both the in-person and the virtually supervised resistance training intervention, we saw significant improvements in self-reported fatigue by multiple measures. And that occurred during the intervention. And then what was interesting about the fatigue was that after the intervention was over, we looked at these patients again 6 months later, after they had been off the intervention for 6 months, and their fatigue levels had returned almost to baseline levels, that all of the benefits that they had gotten during the intervention were basically lost by that metric. So it was interesting to us, and it was sort of encouraging to us, because it speaks to the importance of not only doing exercise, but it's not like a one and done kind of thing. You have to continue the exercise. So for us, we're really interested in focusing on, adding aspects that will make these interventions more durable and have more durable and lasting effects, so that from a public health standpoint, more patients can take advantage of and also have lasting effects from these types of interventions.
Absolutely. It's a really important finding. So along these lines, do you have any next steps or future directions for continuing this research?
Yeah. So as I mentioned, we would definitely like to focus on some, behavioral theory that we can add to the interventions to make them more durable. But we would also definitely like to really refine our understanding of what is the proper dose, how much exercise needs to be done in order to start to see an effect? I mean, we think that a lot of the trials in the past were like 3 months or even less, and we are pretty sure that that's not enough. And that's why we focused on 6 months. We actually have we have an R01 that's pending that is going to be a 9-month intervention. And so, and it's a supervised resistance training intervention. Again, it's virtually supervised. So that we're going to be, it'll be interesting for us to see if not only if we can keep patients on the intervention for 9 months, but if there are additional benefits that are not realized at the 6-month point. So dose, duration. Yeah, and the other thing that we're interested in our research lab is extending this research to precursor conditions. So multiple myeloma is one of the few cancers that has really well-defined precursor conditions. So monoclonal gammopathy of undetermined significance and smoldering multiple myeloma. And so there's an opportunity here to say, okay, what can we do to reduce the chances that a person with a precursor condition will progress to multiple myeloma? And maybe exercise is something that will improve, improve immune function, will improve, other things that could actually derail the cancer progression pathways. But in addition, these patients will feel better. And so we want to, we have some grants in the works where we're going to apply for funding to do these interventions in precursor patients.
Awesome. It's really exciting to hear about as well.
Yeah, thanks.
So for the results of this study, is there any way that they can be used to help inform exercise planning for patients with multiple myeloma, or anything that clinicians can keep in mind in light of these findings?
Yeah, well, the sort of the traditional philosophy, as I said, was it's not safe for these patients to exercise, but we're finding that it can be safe for them to exercise, and there are potentially benefits. But the most important thing in this population is no exercise should be done without the supervision and the direction of a doctor, because the doctor will know the patient's unique situation, their structural vulnerabilities, and whether it is safe for them and what types of exercise they should avoid. So I really strongly caution anyone who is listening to this that if they're not to just go out and join a gym and get a trainer, because a trainer is not going to know, unless they've worked with this patient population before, what the vulnerabilities are. But if it's done under the guidance of a physician and someone who knows something about the particular vulnerabilities that the patient is facing, then it can be a potentially safe and beneficial thing to do. So in addition to the psychosocial, these patient-reported outcomes that we saw some improvements in fatigue and pain, we also previously reported that we saw improvements in some aspects of immune profile and physical function, things like leg strength and gait speed and grip strength and things like that. So there's certainly, it's if done safely, it's not going to make a patient's life any worse, and it could make it better. So it's something to explore.
Absolutely. So as I wrap up today, anything else you'd like to mention about this research, or perhaps any key takeaway messages for both clinicians or for patients as well?
Yeah, I mean, I guess I want to really thank the patients so much, because they gave so generously of their time and their energy. And this is not like a typical study where you fill out a questionnaire and you give a tube of blood and you're done. I mean, this study really required some commitment. And so the patients, I mean, we cannot say enough to express our gratitude to the patients. And so want to mention that, but also some of the patients, there's a lot of evidence that is, we consider anecdotal evidence from this study, that is hard to really capture and put numbers around. But we had patients just at the end of the study say things like, well, I was finally able to take my dog for a walk, or I can finally open that jar of sauce, or I can get the turkey in the oven, things I wasn't able to do. And these are little aspects of daily living that we don't think about, that you take for granted when you're feeling well. But then when you lose the ability to do these things, it is so impactful for your daily life. And so it's great that we have all this anecdotal evidence too, that patients are benefiting from these studies. So we think, it's, the jury is out, it's very hard to prove anything definitively, but we just keep doing these studies, hoping that the preponderance of evidence will point in the direction of physical activity, specifically resistance training, being beneficial for this population.
Absolutely. And that's really wonderful to hear how much it really helped the patients. So great. Thank you so much, Janine, for coming on today to tell us all about this research. It's such important work, and it was really great to hear about and share with our audience. So thank you again.
Oh, it was so great to be on here, Kira. Thank you so much for reaching out and for your interest in our research.
Absolutely. Look forward to talking more as well as additional research is done.
Yeah, we'll maybe see you next year in San Diego.
Sounds great.
Okay, thanks.